My indications for toric IOLs, Nicole Frame.
Okay, great. Thank you to Ed and Kevin for allowing me to speak today. These are my financial disclosures. We're going to talk about a lot of different lenses. I think Mitch Weichert explained to us the importance of astigmatic management and that we really want to be half a diopter or less when we're using any lens, because I think any patient is a premium patient, but especially when we use our toric lenses or diffractive IOLs. And the assumption that we make is that the cornea is perfect and measurable and regular. Preoperative considerations, we want to examine the patient, do a refraction, get an auto-refraction. So we're going to use all these things to put it all together. You're going to have topography and tomography, and you're going to have biometry, and you're going to use your online calculator. So this is your kind of first step to approaching these patients. Next, I don't want us to forget what is important about looking at the AR and what they're wearing in their glasses. And this is not in their glasses when they have the cataract. Hopefully it's previous glasses before they developed a visually significant cataract, because this can give us clues on how much astigmatism that this patient will actually tolerate in their corrections. So when we look at our biometry, we want to make sure that it's reliable, and whether everybody doesn't have 2 biometers in their office, so bringing them back and doing another biometry evaluation is good. We want to make sure that the astigmatism magnitude and the astigmatism axis are close to each other. And we're going to go through a case in just a moment. And these are examples of the online calculator. The Alcon actually has the Barrett incorporated, and the other calculators are very helpful, as well as the Baylor nomogram. But let's talk about and elaborate a little bit what Liz Yu was talking about with posterior corneal astigmatism. The posterior cornea acts like a minus lens, and it creates this net plus power along the horizontal meridian. So posterior with the rule astigmatism is like against the rule astigmatism. And Koch and all his colleagues have shown that with the rule, we can get an overcorrection of about a half a diopter if we don't pay attention to it. And against the rule, it's about 0.3 diopters, so we must pay attention to it. But depending on the reliability of your case, you can have an average gestalt of how you're looking at this. So with the rule, we treat greater than 1.25 in our practice, and against the rule, it's actually greater than 0.75 if it's regular and reproducible. Now, these causes for residual astigmatism, you do a perfect surgery and the patient comes out with a flipped axis. We were talking about this earlier. It's posterior corneal astigmatism, but some of those patients, Kevin, as you were talking about, could have IOL tilt. And as the capsule is actually fibrosing around the optic, you could have some IOL tilt, and Mitch Weichert has done some beautiful work on this. And that's maybe why it's there, and then it goes away over time. And if it's at 90 degrees, there was more tilt that was associated with astigmatism. So we're learning more and more about why we're having this residual astigmatism. Now, I'd like to go through a little bit how we're going to mark our axis. So some of us are old school, and some of us are new school, and some of us do both. There's nothing wrong with manual marking. We just have to pay attention to how we're doing it. And then new school, there are some digital or intraoperative marking systems that can be very helpful. Manual marking is best done if you're at the slit lamp. So if you have a slit lamp in your OR or along the way, you can actually do that in the upright position, because most of us just kind of eyeball and do it, and I get to the OR sometimes and I think, who did that? I didn't do that. So it's extremely important. Next, Bobby Osher has pointed out how these marks can have huge error. And so remember, for every 1 degree of error, you lose 3.3 diopters of astigmatism. And he has this elegant marker with a BVI that's a cautery marker that you can use. Let's get through a case presentation. So how are we going to incorporate this into our practice? So we do topography. I'm looking at the AR. I'm looking at the manifest refraction. It's 2.22 diopters and approximately at 85 degrees. IOL master 1.75, 1.96. So I'm feeling good. I'm feeling like the cylinder is definitely reliable. And then our toric calculator recommends about 1.5 diopters. And this is with the rule, so it's making sense to me. So we're going to get into how we can use intraoperative aberrometry to help us during these cases. I don't use any viscoelastic, but if you do, you can use Provis because it won't change your readings. We hydrate the incision just at the roof to not induce too much astigmatism, like to clean the lens epithelial cells. And then that first image was actually the intraoperative aberrometry reading about 2 diopters of astigmatism. Then we're going to go ahead, make sure we go behind the lens and get all the viscoelastic out. And we can rotate this lens bimanually to make sure we have full control during the case. We rotate that lens Then we make sure that we're pressurized, and now we're going to go ahead again and do our intraoperative aberrometry and make sure that we have residual astigmatism less than a half a diopter. So right here, it's taking the readings. At this point, we're seeing 0.29, okay, a little bit of with the rule left over at 109, so we're feeling good. Then we're going to make sure the lens is centered by using the coaxial lights, and we're going to make sure that everything is watertight, not too pressurized, and use Reassure sealant, because why wouldn't you use everything you have in your OR? So next we have this postoperative outcome. Actually, the aura pushed me into using a higher power lens, even though it was with the rule. So it wanted 2 diopters, and it had a residual of 0.23. And then we confirmed this by looking at our Marco 3D wave, and it's showing only about 0.25 diopters of residual astigmatism. So this is how your intraoperative aberrometry can help you during the case. Now, the digital marking systems are the intraoperative marking systems are very nice, but they're also very expensive. I think if you have intraoperative aberrometry available and you follow the tenets of having a cornea that looks good, you can use it. There's also the Callisto that you can use, but I think surgical steps to minimize your postoperative rotation are going to be meticulous measurements and marking preoperatively, using some sort of intraoperative marking system, removing all the OVD from behind the lens, and then pushing that optic posteriorly after you get all the OVD out. And then the one final pearl, and I think this has been mentioned over the years, but I want to re-emphasize this. Right at the end of the case, go ahead and put a little flush of BSS or your intracamerals in. If you see a little flush of the BSS go in and the lens wiggles a little bit, you can feel confident that you need to reposition. So here's my intracameral stress test. We're going to go in and put like a big flush in, make sure that cannula is on really tight, and then we can make sure that we have no rotation of that lens. Better to do it with BSS than intracamerals, because you want the intracameral to be the last thing that you put in the eye. So the take-home points, depending on the reliability, with the rule I treat about greater than 1.25, against the rule 0.75, and then we want to mark the cornea and use our intraoperative tools. Thanks so much.
Priya?
So Nicole, I think, and Bill, you both said you're doing intraoperative aberrometry. It's something that I use as well. Do you have any pearls on how to decide if you should trust your reading? One of the things that I think took me, many cases to figure out was the surface of the eye having the right amount of lubrication, the tension, the pressure. Can you walk us through, for those that are maybe just getting started with aberrometry, how do you know when to trust?
Yeah, so I think you should do your first 10 cases, without following what Aura says, and just get used to using the equipment. You have to have a pristine cornea as much as possible before you do your measurements. So if you see that you're hydrating your main incision, this is not the patient that you believe Aura. You have to check your preoperative data that went in there. So Aura doesn't directly measure Ks. It doesn't measure axial length. The light rays go in, they come out, and they're using information that you put in to go in the Holiday Virgins formula, then having an aphakic refraction that then gets plugged in and for a power estimation. So you can't really think that it's actually doing a direct measurement. If you see that the cornea is getting dry in the pre-op area, you can use OcuCoat during the case, but just make sure you take it off. And then when you're looking at your readings, if you have greater than a diopter of astigmatism and you're seeing that the axis is within 5 degrees of each other in the aphakic reading, you can feel confident that you're getting good readings. But if it says 1 diopter at 90 and then 1 diopter at 30, 1 diopter at 70, you're not getting good readings. So you shouldn't just trust the Aura as a magic box that's going to tell you what to do. You have to look, if every other formula is telling you to do one thing and Aura is saying, Aura is the outlier, we use it as the decision breaker, not the decision maker.
At what level of astigmatism do you jump to a toric lens? Now, when do you do phaco and steep axis? When do you do paired relaxing incisions? When do you start a toric lens?
So basically, I'm always planning. I tell the patient if they have greater than a diopter of astigmatism with the rule, and they have greater than 3/4 of a diopter of astigmatism against the rule, I tell them I may use a toric depending on what happens intraoperatively. So with the rule astigmatism, I am typically telling them we are just doing arcuate incisions, but if I need it. But if I have gotten in there and the Aura is really telling me reliably that there is residual with the rule astigmatism, and then I'll go ahead and use it. I do like to leave -1/4 diopter for sure with the rule of astigmatism, but there are cases like this case where I was fooled. I was going to put 1.5 diopters of astigmatism, but actually he needed 2 diopters of astigmatism, of correction. But I'm going as low as 0.75 for against the rule, and oblique.
Indications for toric IOLs in post-LASIK, post-RK, do you do it or no?
Yeah, I do it, but this is where looking at what they were wearing in their glasses previously is really helpful for me. So I've had a patient that's wearing only a diopter in their glasses, but my topography says that they need 3 diopters of astigmatism correction. And so that's where I think Aura is extremely helpful, because even though it's not directly measuring the posterior cornea, if you have reliable readings, it's giving you an aphakic refraction and indirectly telling you what the refractive power is of this eye.
Thank you very much, Nicole.